Welcome to Conspiracies Against Wellness with your host, Janelle Elgaway.
Good evening. Welcome to Conspiracies Against Wellness. I'm your host, Janelle Elgaway. If you have a question for our guest tonight, please call in at 415-915-2291 or call 1. You can also live chat with me on our YouTube channel, Conspiracies Against Wellness live stream. Tonight, I have two guests for you, Call Nation, Jen Barnhouse and Dr. Richard Lawhern. Jen is a resident from Ohio and recently met with our state legislatures to discuss being an opioid refugee and how Daniel's bill not only doesn't help being an intractable pain patient, but it won't help the addiction issues going on within Ohio. She's going to walk us through her meeting and the outcome. Then Dr. Lawhern and I will discuss the facts and fears of what is going on concerning the opioid crisis within the U.S. Is this real? How can we fix this issue? Because if things don't move in a different direction and the correct education isn't brought to our lawmakers, there are going to be a lot of deaths. People have and will continue to take their lives because they won't be able to live in this agonizing pain they are forced to live in. There are going to be several new epidemics popping up, not just the opioid epidemic. So good evening, Jen Barnhouse and Dr. Lawhern. How are you?
Just fine, thank you.
I'm happy to have both of you. I'm going to start out with Jen, and then if you wouldn't mind staying on the line in case anyone calls in with a question. And are you going to be chatting on YouTube Live with everyone as well, Jen?
I will be.
Okay, great. So you live in Ohio, and you recently went in to meet your legislatures. Can you please tell me a little bit about yourself personally? Whoa, here we go. Sorry about this. I have the wrong things. Can you please tell me about your meeting a little bit and how it went? How did it all come about?
Well, Janelle, thank you again for having me so much. And this whole thing for me evolved because of my personal situation. A little bit about my background. I was a nurse for many years, and over time, I ended up having to get out of nursing because of some health issues, and I'm in the intractable pain community as a result. And when things started getting bad in the state of Ohio, as it is across the nation for all of our intractable pain patients, there became a really big issue for me personally, because I lost access to my pain physician, and I ended up just in a really bad situation. And I guess many people across Ohio, across our nation, are going through the same thing. And it really threw me through a loop, and I really didn't know which way to turn. And after I kind of got myself together, I decided that I had choices in the matter, and the choices were that I could suffer and, put my pain out there, or I could do something about it, and I decided to do something. And, going through this whole legislative learning process for myself, just nothing I ever knew how to do, but it just seemed that this was so wrong, and the more people I talked to, the more that I realized this wasn't just me. This was just thousands upon thousands of people, and, something had to be done. And I just started looking on the internet to figure out how to do this. What would be the best way to go about doing something? How could I make a difference? And through a whole series of things, I met some people in the community, and I started hearing people talking about reaching out to legislators, and thought, that might be something I could look into.
Okay.
But
so let's walk through this. So, if people are on the fence to call their legislature, how can you explain to everyone how to do this, and what did you say?
I ended up going onto the computer and looking up just putting in, Ohio legislature, doing a search and looking it up and finding information about how to get in contact with your local representatives and senators. And, if you go on whatever state you're in, I did my Ohio. I went to, Ohio legislature, and then, you can follow the links to your government. And I just followed the, contact numbers, and you can find all of your information that way. If you get the numbers, you can get addresses, you can get email contacts. It's all on there. You just need to take a little time and do the research. Not be afraid to do that.
How did you know who to call? Just through research, or somebody tell you?
Yeah. No, I really, it was just, this was too important to me personally, and it was too important to our community and to people around into our lives and our well-being. And you just look and you just decide, all right, I'm going to do this, and I'm going to call. And I decided to do my research, and I started there, and it was a learning process going forward.
How did you find out about the bills in Ohio and what to talk about or what to focus on?
Well, the more I got involved in this, I became affiliated with ATIP, the Alliance for the Treatment of Intractable Pain, that group of people who had very similar thoughts about what they wanted to do. Everybody in the organization wants to do some action to try to, let our legislative people know at our state level or federal level that we exist. We need a voice. And I'm sorry, what was part of that first question?
I was just wondering, how did you find out about what bills you were in Ohio? And you answered that. So how do you make these appointments? When you call, what did you say to these people? Can you walk us through, what how it went, and were they nice to you?
Oh, yeah. I once I got the information, the contact info, I called them up. And usually it's a legislative aide or an assistant, and just tell them that, you're a constituent in their area, and you had some concerns, or for me, in my case, it was dealing with this bill that I had issues with, and I wanted to discuss. And they, just say you'd like to either talk with them or you'd like to set up an appointment. It's just as simple as that.
So how did you prepare for your meetings?
Oh, I spent a lot of time talking with a lot of people, reaching out, utilizing people from ATIP and people online and the Facebook communities, people who've been there, done that. But also sort of just taking a breath and saying this is too important for the greater good, and we all needed to have our voices heard. And I didn't want to lose, the rights that we had.
Did you take anybody with you to these meetings? Should you take anybody, like a family member, doctor, another advocate? What would you suggest would be the best thing?
My experience is that if you have the opportunity to get in front of your legislator or a legislative aide, to take someone with you, the more faces that these legislators see, the more that they understand that we're real people this is affecting. And it's really important. So if you are talking in your community and you know people that are being affected by this and they're willing and able to come, try to figure out a time when you can do it.
What should you wear to these meetings? Does it matter?
I sort of wanted to be myself. I didn't dress up too much, but I wanted to be, appropriate pair of nice dress slacks and a nice top and, be respectable.
Okay. So the day of your meeting, how much driving time did you give yourself? Did you know the area before you went? Was parking easy? Are these things that you should think about before you go and do this?
Absolutely. I did a research of where I was going, how long it would take me to get there, the weather in Ohio here was particularly bad, so I left extra time for that. Looked into with the parking, and I think when you talk with them about making the appointment, you certainly can ask, what parking, where is it, where should I go, and things like that. They'll direct you. They'll give you that information.
So once you're at the building, what did you need to get in? Did you have to go through security? Was it fairly easy? Does it take a long time?
No, it was very simple. They tell you you're going to get off at this elevator and you're going to need to go to this desk and you'll need to sign in with security. You'll need your ID with you. You'll need to have a picture ID, and they'll sign you in. They'll give you a guest badge, and then they'll send you up to the legislators, the waiting area. And from there, they will come out and get you when it's time.
Was it easy to find the room where the meeting was at? Or?
Oh, it was very easy. Like I said, usually when you set up the appointment, they're going to give you it's the 11th floor, or, and here's where you're going to go. And, if you have any questions, they'll say, feel free to call and ask us any questions you have.
Okay. Yeah, because I know when I went to the D.C. meetings, I had to get on a metro, then I had to go, we got lost on that. Then the buildings were far apart, and, we had meetings, the first one was at 11 and then one at 1, and we probably should have put more time in between them because they run over and it was hard to get to. So just a suggestion out there if anybody goes to D.C. Did you bring anything for the meetings, like documents? Did you read off anything, or, what was that part like?
For me, I made sure, because I was going about a specific bill, that I knew that bill inside and out to the best of my ability. And when I wasn't able to understand all of the stuff that was in that bill, I was able to get help from people in, the community that were. But to prepare in general, I just, I took some information I got from the various support groups that I'm affiliated with and just tried to prepare my thoughts about what were the most important things that I wanted to get across to the legislator.
Okay. Were the meetings on time? And was everybody on time?
They were. Yeah, absolutely.
And who did you meet with?
I ended up meeting with State Ohio Representative Jay Edwards and his legislative assistant, Jacob.
Okay. And were they the people that you were supposed to meet with, or did anybody pop in at all? Or?
No, this was a very, I would say I think it was a little bit more formal than I had met with representatives prior in my local community, and that was a little bit more laid back. This was a little bit more formal, but essentially just going into his office and sitting down and discussing things.
Excuse me. Were they friendly? Were the people friendly and easy to speak with?
Oh, Representative Edwards and his aide were very willing to listen, and I think the point that I came away with that was, I think, the most important thing to me was it seemed very evident that they wanted to hear from individuals, and that being in front of him was very important. Apparently, they see a lot of lobbyists and a lot of organizations being represented, and when those people come in over and over and again, I think the whole sense of the politics gets lost. And he said that I was probably one of the very few people who had come in as an individual to talk to him. He said he wished more people would do that. Wow.
Yeah, I think when we talked earlier, you said that they said that, yeah, you're the first real intractable pain patient that sat in front of them. And didn't they want you to, they said that they would want more to come in, correct?
Absolutely. They encouraged, people that was the biggest thing, that they really were more interested in hearing people's stories. They wanted to, understand what's going on, because again, day in and day out, they deal with all these other people, but to know what's really going on, to get the real story, it's so important for them to see our faces, to be able to put the faces with the stories.
Right. What did you bring? Any information packets, anything that you left with them, or to present to them?
I did. I had some information that I had a binder that I gave to Representative Edwards of just really important stuff that I wanted to get across, and I gave that to him. But in addition, because I was dealing with this bill for Daniel's Law, I took a packet of information for each one of the House and Senate healthcare committee members to have, so that they, with a kind of a cover letter that said I was visiting with Representative Edwards about this, and that, I hope that they would consider the input and this information I was giving them. So Jacob was able to take that and distribute it to all of those members. And so this gets in front of them. It's another way to get information from an individual to them.
Was this easy overall? Would you say this, or was it, how did you feel?
I'll tell you, to be honest, in the beginning, again, this is not something I've ever done before. In the beginning, it can be really intimidating and scary, but what I will tell you is that they, I even said in my meeting at some point that I got nervous or flustered, and I said, I'm nervous. I have not really, this is not my area, this is theirs. And he said to me, don't be nervous. That, we want to hear from people like you. There's nothing, I'm just another person. And so I came away feeling really good about the whole situation. I really felt like we were heard.
Mm. So, did they ask you any questions, and did they appreciate that you came in, and what was the outcome of it all?
I think it was wonderful because in the end, in explaining, becoming more and hearing my story from a personal level, I said to him, help me understand a little bit better how this process works. How do you get people when you're deciding on bills like this? How do you decide who comes to the table to help you make decisions for us? And he said, if you want an invitation to the table, you have it. You're welcome to come. And so I was thrilled.
Congratulations.
Yeah, it was wonderful. Thank you.
Wow, that's awesome. Okay, so overall, now that you're out of there and stuff like that, looking back, what do you have to tell to all of our listeners out there that are kind of like interested in doing this or afraid, but are, they don't think possibly that they'll make a difference or that they can do this? What do you have to say to them?
I'm going to tell you, I know it can be scary or intimidating, but there are so many people, first of all, out there that can make a difference. And if you want to have a voice in this, you've got to put yourself out there just a little. And it's really not nearly as scary as you think it will be. And it can, one voice can make a difference. One face putting a story to it and letting them see your face makes a huge difference. Mm-hmm. And I just think, in Ohio, we have this huge window of opportunity right now, in particular with this bill and with everything, with the climate, to make a difference. So if anybody's on the fence, I would encourage them. People are welcome to call me or contact me if they have concerns or questions. I'll walk them through what I went through.
Well, and if anybody out there is listening and they want your information, I could give it to them. But did you want to give out like an email or something online? Or I know you'll be on YouTube, that you could do it too.
Right. After I'll stay on, and if people have questions, they certainly feel free to ask me.
All right, great. Well, Jen, thank you so much for coming on. I think it's really important that people hear what it's like when you go to these meetings and how did you prepare and everything like that. And I know ATIP is working really hard, and a whole bunch of other groups out there are working hard to prepare people so we can go in and do this, and it does make a difference. And I think at the state level is where it's at. I know a lot of us agree on that, and I think we can really make some changes. So thank you for doing this, and congratulations, and I'm so proud of you. That's so awesome.
Oh, thank you, Janelle. Thank you. And again, I just I feel honored that you guys had me on here. And if there was one thing I could leave everybody with, it's just if you have even a little bit of the inkling to want to do it, please do. This is the time.
Absolutely. All right, Jen. Well, we're going to switch up here. I know you're going to be online still with us, and if anybody wants to call in later, you can call in. Jen will be here to answer questions, but she'll also be on YouTube Live. So we'll talk with you in a little bit, if that's okay. All right. And now we're going to go to Dr. Richard Lawhern. Are you there, Dr. Lawhern?
I'm here. I hope I'm connected.
Somebody asked me quickly, I'm going to just go to this. On YouTube, Rose Bingham says, Janelle, is there anything you forgot to say and wish you had to the legislator or wish you had said? My experience is a little bit different. We had a whole bunch of people in the room. Yes, there is a lot. I wish I said, I know next time I will go in, and I've learned so much, so I will be able to do that then. Also, I've worked with a few people, like from ATIP and a few people from other groups that has helped me to learn of how to do things better. I think what it is you just have to go and do it. Obviously, you want to have a prep of about 5-10 minutes and kind of know what you're going to say, your main points. Have information that you could give out to them or examples so they can see it. The people that we went to wanted stats, wanted numbers and stuff like that, wanted to know about constituents and everything like that. But like as Jen just said, though, they wanted to know about her personal story, which it would have been a lot easier if they wanted to know my personal story, because I know we kind of all threw this together in 3 weeks. So, but I do want to go again, and hopefully I'll be more successful every time I go. And I think that's what it is. You just have to get out there and do it. So, all right, Dr. Lawhern, can you please tell me a little bit about yourself personally and what your professional background is in?
Okay, that could be a long story. I hope I'm audible. Am I coming through properly?
Yep, we could hear you.
Okay, very good. I got into chronic pain communities by trying to help my wife deal with a very rare neurological disorder 21 years ago. And my wife came down with a disorder that is now generally called neuropathic face pain, sometimes called trigeminal neuralgia. And it took us a year and 6 doctors to find even a diagnosis, even a guess at a diagnosis. And in the process of going through that, we finally found a neurologist that thought he understood what she was dealing with. Trigeminal neuralgia is kind of an orphan disease. And we went to a support group that was meeting in our area, and that time that was D.C. and Maryland. And we met Claire Patterson, who was there to speak. She was the president of the U.S. Trigeminal Neuralgia Association. And I asked a rather leading question from the audience when she'd given her presentation, and that was, I asked her, what are you doing to increase the visibility of the disorder that this audience shares in the Internet? And she crooked a finger in my direction and said, I want to talk to you after the meeting. And that started a process. I became the webmaster and principal research analyst for the TN Association. And from there, I have branched out into a number of other areas where I've been essentially a non-patient helping other patients as a family member and caregiver, and doing so in the context of peer-to-peer social media. Now, I should make clear, and this is a necessary qualification to your audience, I'm not a medical doctor. My training is in engineering systems. My doctorate is from UCLA and a long way back. And a lot of my experience was in technology evaluation and information mining, and basically I was a learning machine, if you want to say that. And I put that background to work on behalf of my wife and then later on my daughter. My daughter also has a chronic pain condition. She, however, needs opioids, and my wife is fortunately able to manage without them. But my daughter has Parkinson's, and she came down with it at age 51. And she has days when the image that you might have of her is that of a female Quasimodo from the Hunchback of Notre Dame, when dystonia so cramps her muscles that she literally bends over and cannot straighten. And opioids are a very real part of the treatment that she has to go through. She's been through multiple surgeries and interventions. And she's been through any number of doctors who have basically said, well, we got to put you through step therapy before we can really seriously consider the next step for your treatment. And step therapy has another name. It's called fail-first therapy. It means they put you through all sorts of things that generally aren't going to do very many people very much good, just on the off chance that they can avoid the expense and the insurance cost that goes with advanced procedures, particularly back procedures, back surgery, and she's been through 3 of them. So, if you want to sum up, I first began looking seriously at chronic pain issues from a political perspective about 6 or 8 years ago. And I did that because I kept running into people who told me, my doctor has told me my pain is all in my head, and I really should just suck it up and deal with it. and I'm quoting now, this is not just an invention. These are things people have actually said to me. So I wrote a number of articles, and one of the articles was researched heavily enough to be peer-reviewed and published in the Global Summit for Diagnostic Alternatives of the Society for Humanistic Psychology, and it was titled Psychogenic Pain and Iatrogenic Suicide. And what that article did was to look at a very large sample of patients who were evaluated for 7 different chronic pain disorders by the Department of Veteran Affairs, and then matched to suicide as an outcome of their cases. And it was a large number out of 2,800,000 or so people that were reviewed. And what we found, what they found, and what I later popularized and expanded on, was that by the simple act of assigning a diagnostic code of psychogenic pain, which is basically pain that's created by your mental state, the doctor will ensure that your risk of suicide goes up by 250%. And that kind of got me started into the chain of exploration and discussion on Facebook and other social media groups, which has led me to become more deeply involved with chronic pain communities being seriously damaged by government policy. Am I being responsive to your question?
Yes. There has been some chatter on social media that come January, all 50 states will only allow doctors to prescribe to chronic pain and intractable pain patients. And I think it's either 100 MME or 50 MME. Is this true that you know of?
Yeah, that asking me that I know of is an important qualification here. I've heard some of the chatter. I have never seen documentary evidence that, in fact, there is any plan of this sort. I do know that a number of state governments are intending to impose one kind of opioid restriction or another beginning in January of next year. Particularly, I know that Washington State, Oklahoma, Ohio, I believe Texas may be on the list, are considering or are at least discussing in various forums the imposition of rules on prescribing. And there are states already that have. I think the most punishing and unrealistic of all of them is the state of Maine. They have already imposed a limit where a doctor has to justify any prescription over 100 morphine milligram equivalents per day. Mm-hmm. And there are exceptions for it. They had to go back in and create the exceptions after there was an outcry from patients and doctors. But it is still highly draconian.
Is this actually a law, or is this they're falling off of the CDC guidelines?
In Maine, it's a law, and it's a law based on the CDC guidelines.
Gotcha.
And justified. And that's really one of the things that I'm complaining of, not to you, obviously, but in the writing that I do on this subject. The guidelines were originally written, and this is back starting in 2014, and then being published in March of 2016. They were written originally with the intention that they would be directed to general practitioners and that they would be voluntary. And the 100 MMED threshold was not a hard limit in that original document, but it was supposed to be an advisory to general practitioners that if their patients needed more than 100 MMED, they should perform a risk versus benefit analysis. Well, our Congress, in its debatable wisdom, threw that into a cocked hat 3 months before the guidelines were published by mandating in a budget resolution bill in December of 2015 that the guidelines would become a mandatory practice standard for the entire Department of Veterans Health Affairs. Mm-hmm. And CDC didn't bother to make one change in the document between the time the VA imposed that limit and the time they published. So, to say the least, there's something cockeyed going on in Denmark with that.
Well, and the thing that doesn't make sense is this isn't a one-size-fits-all thing. I mean, what if you have a 350-pound man and a 120-pound woman, or like, they're going to need more, obviously. Or if somebody metabolizes more quickly, they're going to need different stuff. It doesn't make sense.
Well, it doesn't, and
right.
It doesn't make sense.
The people that wrote these, there was no actually pain specialists on this board when they were creating these guidelines. And
let me add to that, if I might. Sure. There were in fact a couple of anesthesiologists. But a precise way of stating that is that there was nobody on the writers group, which was called the Core Consultants Group. There was nobody on the writers group that had ever practiced in community practice in the routine management of patients over a prolonged period. And also, there was no expert in medical ethics on that panel. There's some evidence, and in fact, there was an actual intervention on the part of the Government Operations Oversight Committee from the House, U.S. House. The whole process was closed. It was not really open to public input. When Congress directed, or the Congressional Committee directed, the director of the CDC to open the process, at first the CDC tried to open it for just 3 days. And then they got told, wait a minute. And they were forced to open it for 30 days. That's to open the process so that the public could submit comments, and so that other professional associations could submit comments. And there were over 4,000 comments received. Now, I've read a lot of those comments, and I can tell you that none of them were reflected in any meaningful way in the document as it was published. The input was received but not acted on. One of the largest areas where the CDC guidelines are absolutely fraudulent, they're dead flat scientifically wrong, and the CDC knew it when they published them, is that the guidelines make no provision for the differences in the ability of individuals to absorb and break down opioids into the products that eventually go across the blood-brain barrier and actually address the pain. And in doing that, they guaranteed that if a ceiling of 100 mmED was imposed, that millions of people would fail therapy. And they either didn't know it or they didn't care. And that is reason one why it is absolutely necessary, and why ATIP as a group is working to bring this to legislators. It is absolutely necessary that the CDC guidelines be publicly retracted and subjected to a ground-up rewrite, because they are scientifically unsupported, biased against opioids. They stacked the research in an effort to disadvantage opioids. They stacked it deliberately, and they got caught at it. And they do not include any provision for variations in the natural dose levels that will help people. Those documents are unsafe at any speed.
Right. Well, even stats that they have for graphs, they will take an overdose death, and if they had a benzodiazepine in their body and an opioid, they'll count them each as almost that they were two different people that died. So their stats are all off. And I was going to ask, why are the numbers on the statistics all over the place? There seems to be percentages, and depending on what you look at, they're different. Why is nobody able to have the same things?
Well, in part, the CDC has actually cooked its books. In part, other advocates have deliberately cooked their books and have made statements that are deliberate hype. They're basically trying to have something to say about the so-called opioid epidemic, which really isn't an epidemic at all. But they're trying to basically force opioids out of common practice by any means, fair or foul. And there's one group in particular that's involved in this, and in fact, That group was very deeply involved in selecting, at least I believe they were deeply involved in selecting the initial group that was supposed to do this writing for CDC. They're called Physicians for Responsible Opioid Prescribing, and there's nothing responsible about them. They were based largely around the University of Washington in the state of Washington, and they had a couple of their members very closely associated with the original writers group. And those members had to be taken off the group when Congress basically said, wait a minute, there's bias operating here. But even after taking them off the group, not very much changed. So when you see the numbers, here's the way they really break down if you get careful. You hear numbers like about 65,000 or so drug overdose deaths. What they don't tell you when they use that number is that something just less than half of those numbers aren't opioids. They're most likely and most often basically acetaminophen, so-called Tylenol, and other analgesics that people overdose on and die of liver failure or cardiac arrest. Out of the remaining 33,000, over half of those deaths are primarily caused by heroin or fentanyl imported from outside the country. And in the somewhat less than 15,000 left over after heroin and fentanyl and methadone diversion and morphine stolen from hospitals are taken out, they might have something to do with an opioid, a prescription opioid, as one of several factors. But over half of that remaining 15,000 involved both an opioid and an anti-anxiety agent and or alcohol. So that takes you down to maybe, if you really push, somewhere around 8,000 deaths that you might attribute specifically to some opioid, whatever it was, that could have been a prescription opioid. But when you push that even further, you find out that probably less than 10% of people who die of overdose involving opioids that are used under prescription actually had a prescription that was current. So the 60,000 probably reduces to less than 4,000 actual deaths that were caused by a prescription opioid that was actually given to a chronic pain patient. That number in the overall statistics is less than 1,000th of 1% of all people who use opioids under prescription. That's not an epidemic. That's hype.
Right. Right. Hey, Dr. Lawhern, we're going to take a quick 30-second break, and we'll be right back.
Coming soon, Call 360 Network. From the same place that you get the Call Show now, you'll be able to get great new shows like Save Our Children, The Opioid Void, Enhancing Your World, Wake Sheep, The Revolution Within, Dr. Klein and the Dope Fiends, and of course, Conspiracies Against Wellness. And you'll be able to get it from just one place without hunting all over the internet. Think of it as your daily dose of truth. So stay tuned. Great things are in the future, and Call 360 Network will be leading the way.
Welcome back, Call Nation. This is Janelle. We are here with Dr. Lawhern and Jen Barnhouse. And Dr. Lawhern and I are going to be talking about the opioid crisis or lack of. We were not sure. If you have a question for Dr. Lawhern or Jen, please call in at 415-915-2291. So, Dr. Lawhern, what kind of crisis would you describe that is currently going on in the United States? Because I think we could both agree that this isn't really an opioid crisis. There's something else going on. What is this to you?
Well, all right. Let me make this a little bit complicated because I want to be fair. We are dealing with an addiction crisis. I think that's a fair observation. Mm-hmm. What we are not dealing with is a prescription opioid crisis. That's a lie. It's not so. There is no medical justification ever for taking a patient off of an opioid prescription when their dose is stable, the quality of their lives has been improved by the use of opioids, and they are otherwise not at risk or not experiencing side effects that destroy the quality of their life. There's no justification for that at all. And the CDC guidelines, as they were published, didn't direct that that be done. But doctors have interpreted the guidelines as a mandatory standard, and the DEA has interpreted the guidelines as a mandatory standard, which they can use as an excuse for hounding doctors out of practice. And in fact, doctors are leaving pain management in droves, and they are deserting patients by the tens of thousands.
Right.
So
well, look at what Jen was doing. House Bill 167 and House Bill 119 that's supposed to save, Daniel's bill. And poor Daniel, he passed away due to a heroin overdose. But what that does really is it first of all, in Ohio, if this goes through, doctors' offices need to have addiction specialist offices there. They have to be certified by it. And I don't know of many addicts that actually go, or people that have addictions will go to a doctor's office. So it doesn't really help addicts, and it doesn't really help the intractable pain patient or chronic pain patient. So let me ask you this. Is there scientific evidence that opioids are dangerous or harmful? Is there scientific evidence that opioids are harmful to a person?
Well, I read an article just today by a gentleman by the name of Forrest Tennant, and he is possibly America's most outstanding and well-known chronic pain specialist and intractable pain specialist. Now, this article was written 2 years ago. And what he has basically said is that there is no scientific proof that opioids cause permanent harm in the body. There just isn't. There are numerous other published articles that also demonstrate that opioids do have a legitimate place in pain management for the long term, even at very high doses. Now, what we've got, and again, this harkens back to the same group that did the writing on the CDC guidelines. What we've got is the assertion that there really aren't very many long-term studies that establish that opioids are both safe and reliable. Now, that statement, if you took it just in isolation, is correct. There aren't very many studies. But what the writers did when they went in to write the guidelines is they turned that statement on its head. What they said was, there is no evidence that opioids work over the long term. And that's flat wrong. There's an excellent article, which I've many times linked from my page and from other groups on Facebook, that was written by 3 MDs who are in community practice. And they are respectively Martin, Poteet, and Lazarus, spelled with a Z, Lazris. And they wrote an article that got me started on a lot of this around the general title, Neat, Plausible, and Generally Wrong, a response to the CDC opioid prescription guidelines. They took on the whole narrative that was behind the guidelines, and they basically ripped it to shreds. They demonstrated that somebody had deliberately confused a lack of long-term studies with a lack of long-term effectiveness. They also pointed out, and others pointed out, that when the CDC did the research to establish just what was the state of our knowledge about opioids, they deliberately omitted any study of opioids that was shorter than 1 year. But they did not omit any of the studies of non-opioid pain relievers or behavioral therapies, and they didn't tell their audience that they had used that criteria. Now, that's a violation of widely accepted research practice. It's a violation of the CDC's own research practice. And a group, which I believe may have been Princeton, went back in and did the analysis, and what they basically concluded was if you took the 1-year criteria and you used it for all of the studies that are available on pain, where opioids or behavioral therapies or non-opioid medicine is used. If you addressed all of those studies, you wouldn't have enough evidence left to stick in a thimble, because there aren't very many long terms. But there's a very interesting study that was done that the CDC conveniently ignored. It was what is called a Cochrane review, C-O-C-H-R-A-N-E review. It was done in 2010. They went back in and they tried to isolate studies from the literature which evaluated the long-term risks and effectiveness of opioids, and the risk of addiction in opioids, incidentally. And when they worked their magic with it was a group of about 5,000 patients in, I'm going to say, something over 10 studies. When they went back and reworked the numbers, what they found was that if patients have not before had opioid prescriptions or had any other indicators for a previous exposure to opioids, among those people, the risk of being diagnosed within 1 year with opioid abuse disorder is less than 0.5%. Now, that compares to the public narrative that a lot of people have bought into, and that a lot of our legislators have bought into, that says, well, gosh, if you take opioid one pill, you're at risk. If you take OxyContin or Percocet or Lortabs for a week, you could be addicted in 2 weeks, which, if you'll pardon my French, is bull feathers. And it's widely understood among pain management specialists to be bull feathers.
Well, I think they even said if you get your wisdom teeth out at 18, and then 10 years later you need to be put on something, your association or something like that, because, and Kolodny says this, because you had that at 18, you're suddenly going to become an addict. That doesn't make sense.
Well, it doesn't, but we need to be careful about understanding why not. One thing that is out there that we have to realize is that when kids are exposed to opioids early, for any prolonged period of time, and we're talking months, there is some non-zero risk of dependency developing and of addiction developing among some of those who become dependent. And when we say dependent, what we mean is that if they stop taking an opioid, the pain comes back. And if they stop taking it rapidly, they will have withdrawal symptoms. But withdrawal symptoms does not mean they're addicted.
Right.
Addiction and opioid dependence are two different medical entities. They're two different things. And that distinction is often blurred, and I think perhaps even deliberately blurred, by people who have a financial self-interest in labeling patients as addicts. One other thing, if I might, I'm rattling on a little bit, so please, yank my leash if you need to, hon. I bothered to go in and do some research for an article that I published in the National Pain Report, and the title of the article was "Figures Lie and Liars Figure: Why the Demographics of the So-Called Opioid Prescription Crisis Don't Work." And to summarize that article in a thumbnail, if you look at the typical chronic pain patient and the typical beginning addict, they're different people. The typical beginning addict is an adolescent male who has a background that includes family trauma, often caused by economic conditions, a prolonged history of unemployment, and possibly mental health issues. And that typical addict is quite rarely seen for any condition of pain that would justify the prescription of an opioid. In fact, people who come from economically disadvantaged areas are typically medically underserved, and especially young men, because young men typically don't, unless they have dental surgery and they're kept on opioids for a very long period, they don't really have an addiction risk that they get from prescriptions. They have an addiction risk that they get from stuff they buy on the street. Now you look at the typical chronic pain patient, and many people in your audience can confirm this. The typical chronic pain patient is a woman in her 40s who has fibromyalgia, failed back syndrome from an accident or from surgery, or a chronic neurologic face pain condition or fibromyalgia. She will typically first have a chronic pain condition that requires the use of opioids well after she's reached maturity, and the odds will go up that she'll have a problem by the time she reaches age 60. And the odds go up for both men and women. But women usually suffer from more severe pain, and they suffer more often from pain. Overall, they have a ratio of 60-40 for all different pain conditions lumped together. And in some pain conditions, the odds of women versus men are over 80% to 20%. And women in their middle years are not at a high risk for addiction. They just flat aren't. So what we have is a description for these two populations which has very little overlap. People who would commonly be prescribed opioids are not, in most cases, serious candidates to become addicts. And people who are addicts are not commonly prescribed opioids. They get them on the street. The demographics do not work. And nothing in the opioid prescription guidelines the CDC wrote mentions that inconvenient fact even once.
Well, let me ask you.
That's another area where they screwed up.
Right. There are guidelines written by pain management physicians and other people that understand and treat intractable pain or chronic pain patients, such as the Federation of State Medical Boards, or FSMB. What is the differences between the CDC guidelines and the FSMB guidelines? And I think Washington State, North Carolina, and maybe Nevada is going to adopt these guidelines. Why aren't these states looking at this? Because these are people that understand this then.
Yeah, well, interestingly enough, the FSMB, as you put it, was developed by pain management specialists rather than by generalists. And they were specialists who actually had some practice background. And that guideline does not mention any specific threshold of risk for opioid prescription. There's no 100 MMED in it. And it's very understandable that there wouldn't be, because there is no one-size-fits-all rule that represents a justifiable or supported threshold of risk. It's just not there. And the guys that did the state-level work...
There's no scientific data saying that it's dangerous either.
I'm sorry?
There's no scientific data saying that this is dangerous. Somebody that is on opioids long-term, they build a tolerance over time, but there is no scientific data showing that there's anything wrong with this. Opioids are actually one of the safest drugs out there, and they're cheap. You know, it's a very easy way for people in pain, because that's what this drug was created for, people in pain, to be able to go on and be able to have some type of normal life, to continue working, to continue having any type of quality of life. That's what this was for.
Janelle, let me add one small reservation on this. We need to be careful about this, because we need to be balanced and fair, unlike what's going on in most of the public conversation. First of all, there is a small, it's non-zero but not large, there is a small risk that some people will become opioid dependent or opioid addicted if they're treated with large doses over long periods. But, and this is a very essential but, the risk is probably less than 2%, almost certainly less than 3% in people who are properly worked up. So if you go,
if I had an addiction towards anything, wouldn't I just be predisposed anyway? So whether it's opioids, alcohol, or whatever that I really, really would like, wouldn't that be the same thing? Like, is it really just because of opioids, or is it because of the person?
Well, there's a third alternative, and we ought to be careful to include it. First of all, there are probably some genetic factors that predispose individuals toward opioid addiction. It's not in a very large number of people in the population, but the number of people who are addicted generally has not varied with over a period of the last roughly 100 years. It's generally around 3%. So that tells us we ought to be a little bit careful to look for genetic factors, because there may be something going on that predisposes people toward addiction. Now, that said, the other side of this is that we know that there are millions of people in the U.S. who not only can tolerate high doses without addiction issues, but they must have high doses in order to get pain relief. They're either poor metabolizers or they're hypermetabolizers. And let's explain what that means to your audience. Just about 90% of all medications are broken down in the liver by 6 enzymes. And I'm not going to make this more complicated than it needs to be, but the bottom line is that genetics controls the expressions of those enzymes. If you get one gene, or maybe it's a gene allele, of a particular type, one of those 6, you get expression of that gene once, and you're not going to be a very good metabolizer for some of the drugs in the opioid class. You get 2 genes or 2 alleles for that particular hormone, or excuse me, that particular enzyme, and you're going to be an average metabolizer. You get 3 expressions of that gene, and you're going to be a hypermetabolizer, and that means that you'll have a dose of opioid that will go through your system so fast that it's gone in minutes instead of hours, even long-release opioids. The other part of this we need to understand is that a lot of people can't really take opioids because there are side effects to them. Nausea is a big one. Sleepiness is another. And cognitive, brain fog is a third in some people. And one of the things that complicates all of the studies that have been done that we know of, and all of them that were referenced in the Cochrane Review, is that the dropout rates are high. People find that for one reason or another, they're not doing very well on whatever dose that they've been given. In a lot of cases, if they're not doing very well, the doctor may not recognize that they are under-medicated. Right. Because doctors are not very well trained in pain. They don't get near enough hours in it during med school. So we've got multiple factors going on here, and we've got to be fair about this. We've got to be balanced about this. There's going to be one huge deficit in doctor training that's going to have to get filled in order to straighten this mess out. And we're going to have to recognize that there's no typical patient, that we're going to have to spend hours evaluating patients on the front end and periodically as they go, because some patients are going to develop tolerance, others aren't. Some patients are going to have serious side effects and others aren't. We're going to have to do trial and error tries of differing opioid and non-opioid solutions. And generally what we're going to have to do is we're going to have to tell doctors, well, plan on at least 2 hours instead of 10 minutes workup on the front end, maybe 4 hours on the front end, with each new patient you get, because if you spend less than that, you're not going to understand what their issues are. Doctors hate that, because insurance companies won't reimburse for it. But that's reality, and that, in fact, is the kind of standard that Forrest Tennant has exercised for years in his own practice. He's been practicing 45 years.
And instead of the $100 billion that Kolodny-Prop and all of those people are asking for, maybe it could be put into training doctors correctly on how to treat patients and having the correct education. I mean, they don't need $100
That can be part of it.
Right.
That can be part of it. The other part of this we have to recognize... No, excuse me. Go ahead, Janelle.
Oh, no. I was just saying, maybe we can work... Because, look, I'm not saying that there's an addiction problem. There is definitely an addiction problem, and they need help. But it's just so one-sided, Let's help everybody here.
Right, and another thing that should be said, and there's something else that, again, I've published in another area. It's not like we don't know what we have to do for either chronic pain or addiction. We do. It's just that there are a lot of people that don't want it done or don't want to pay for it. Addiction is not a disorder of drug exposure. It never was. Addiction is a disorder of social disintegration. When communities and families break down under economic stress. We know that in order to prevent addiction, we have to start in grade school. And not all programs work to help get kids up to speed and help them understand that when they face a pusher, they're facing a killer. As for instance, under the Reagan program, Just Say No was a miserable failure. But there are other programs of preventative education that have a much better outcome. We also know that we don't need any more beds in 30-day detox facilities. We just flat don't, because they don't work. And they don't work specifically if they're the only thing you do. We also know that Narcotics Anonymous has just as high a relapse rate as the detox centers. It's around 90%. That doesn't work by itself. In order to address addiction and to provide people some route for getting out of that particular form of hell, we're going to have to be prepared to spend billions of dollars every year in what are called community reintegration and medication-assisted therapy programs. Medication-assisted therapy is basically methadone or buprenorphine. I can't say that word for diddly, I'm sorry. But basically the two replacement drugs that are used to taper people off of things like heroin. You start with that and you look at it as probably something that you're going to have to use long term. We also know that what you desperately need is some place for people to go after they complete detox. That means safe housing or sober housing, job training, and employment workplace development that will generally start with programs in Medicare and Medicaid, which our Republican colleagues are trying to kill off. And conservatives in general are trying to kill off because they want to downsize government. I've got news for the conservatives. That doesn't work. If you take an addict and you put them through a detox program and put them right back into the same community circumstance that made them vulnerable to drug addiction in the first place, you ought to have your head examined because that's a guarantee of relapse. You also have to treat these people in their communities for the mental health disorders that sometimes are actually issues, I should say, the mental health issues that are often involved in addiction. And the process is not going to be perfect, but the process requires investments of billions of dollars a year.
Is there anybody in the world that's doing this correctly right now?
Yes.
Who?
The state of Portugal learned a tremendously valuable lesson starting in about 2003. They decided, after doing a lot of serious investigating on this, that they were going to decriminalize the possession of drugs. That doesn't mean that they're going to stop prosecuting pushers, because they're still doing that. But they decided that possession of drugs would no longer be a grounds for arrest and imprisonment. Even our Christie Commission, despite all of the other screw-ups that they committed, they recognized that diverting people out of the prison system is really a necessary step at this point. Now, after something like 17 years in the state of Portugal, the number of opioid-related overdose deaths has dropped to almost zero. Mm-hmm. And the number of new addicts is beginning to drop at the margins. It hasn't been a huge movement yet, but it is definitely a reduction in the state of Portugal. We also know from studies in the U.S. that were done by the RAND Corporation for the National Institutes on Drug Abuse, that in states where marijuana is legal and where it is administered through actively managed dispensaries, the rates of opioid prescription are dropping, and the rates of opioid-related deaths are dropping. Now, it's not a huge drop. I don't want to make this out to be the miracle cure, because it's not. But we know that there is value in medical marijuana as an alternative, especially for pain patients, for many of them. And yet we still deal with an attorney general who is determined to prosecute marijuana even in the states where it's legal. This man is an idiot. And I think anybody who studies his policies is going to be forced to realize that he is. However, a lot of people aren't studying yet. That's what your first guest, as a matter of fact, was speaking to. Something we didn't mention up to this point, if I can interject it, if you don't mind. She mentioned ATIP, and I want all of the people in your listening audience to realize how they can find ATIP. And I have to be, straight with you guys about this. I am one of the co-founders of that organization, and I am its corresponding secretary. I sort of keep track of who's doing what. And there's another leadership group who works that problem with me. You can find us by going on Facebook or by going on Google and entering the term Alliance for the Treatment of Intractable Pain. We have a Facebook group. We have a website that is in the very, very, very early stages of getting underway. We are not ready to release the full area, the full dedicated website yet, but we have a temporary home on the web that has been loaned to us by a lovely woman by the name of Erica Conrad West. And you'll find it in a Google search on Alliance for the Treatment of Intractable Pain in the top 10. And that website has on it a good number of the information materials that we're trying to provide to patients and to family members who want to go lobby, who want to go talk to their legislators, just as your first guest did. We're trying to take the process that she had to go through for her learning about this and reduce it to a few documents that you can read and understand how you go about all this and what things are useful to say and what things are useful to leave behind. The process, as she described it, does involve some learning. It does indeed involve, I would say, a certain amount of take a deep breath. Jen went through that, and she had the professional background to do it. But I would say that if we had to have a tagline, ATIP's tagline, and I'm indenting this on the fly, so I beg your pardon for anybody who's already a member. Our tagline could be, put a human face on pain. And then, by implication, put that face in front of a legislator or their staff. We need to get organized, and we need to get people in front of legislators in all 50 states. ATIP is in the very early stages of helping to promote that outcome. But I don't think a day goes by when somebody doesn't come to us and say, what can I do to help? How can I talk to somebody and make a difference? And I want to emphasize something that Jen probably didn't say in quite this way, but it's very much true. Petitions won't help. Emails don't help very much unless they get them by the tens of thousands. The thing that does help is putting yourself in front of a legislator and telling that legislator or their healthcare legislative assistant or their staff generally, I'm here to tell you, you are destroying my life. And there's only one thing you can do for me to fix it. You can co-sign a letter to the chief or the director of the CDC, and you can tell him your budget is going to be reduced 10% a year until you revoke and rewrite the CDC opioid prescription guidelines because they're wrong and they're killing people by the hundreds. This is your fault. You fix it.
Right.
And if you heard anger in my voice, I guess there is a little. And we do need to be polite, folks. I mean, let's be straight with each other.
Yeah,
nobody likes to be poked in the eye with a sharp stick.
Exactly. No, but you're right. This is very serious, and a lot of people are dying. Would you mind if we took a call?
Yeah, sure. Go for it.
Okay. Caller from area code 574. What's your name and where are you from?
Hi, this is
Hello?
Marty Wolf. Yes, hi, this
Hi,
is
Marty.
Marty Wolf, South Bend, Indiana. And
Hi, what's your question?
for Dr. Lawhern, first of all, I'd like to thank him so much for everything he's done for us in the chronic pain community. I'm 12 years diagnosed with CRPS, which is considered the most painful condition known to the medical community. And I'm a member of several closed Facebook groups for people that suffer with chronic pain. And I think you just answered one of my questions as to what we can do to change the direction of how this is going, because my pain doctor, who spent 2.5 hours with me before he took me on as a patient, questioning 9 of my foot surgeries before he started prescribing to me, is now, because of all the hype with the March 2016 CDC opioid prescribing guidelines, is under a lot of pressure, and he's cut back my medication. And it's not because of my condition improving. It's solely because of all the governmental pressures being put upon him, and he could lose his practice. So I did go before my legislator, Jackie Walorski, and I met with her assistant, and I was very well prepared before I went in there. And I spent what I expected to be a half-an-hour meeting. I spent over 2.5 hours explaining my situation, explaining CRPS, complex regional pain syndrome, to her, and I thought I made a great headway. However, I've heard nothing back, and I've tried several times to contact them to find out if Jackie Walorski is taking my meeting seriously. And then secondly, my question is, there's got to be some sort of money driving this. Chladni and all this business that he's involved in, there's got to be something that's pushing this. Can you help me?
May I respond to your 2 thoughts so far?
Yes, sir.
Yeah, okay. First of all, there's a piece of every interview that we're going to have to find a polite way to do. And that is, before you leave, we need to ask the people you've just briefed, okay, what I've asked you to do is to take action, not just to hear me, but to act in a particular way. So right now, here between us, you tell me, how am I going to know that you've taken action? That's the closure. And that, closers are people who actually close the deal, and that's the step that very often we don't do. Now, beyond that, you ask about the money trail, and this is a really tangled skein. So be aware that there are some uncertainties here. Basically, insurance companies they absolutely hate chronic pain or chronic anything because it's expensive. Insurance companies don't want to pay for expansions of coverage. And if chronic pain was being treated properly, the expansion would be major. And insurance companies have been quietly lobbying behind the scenes, trying to force hard limits on opioids with quite a number of different U.S. agencies, but particularly with the Centers for Medicare and Medicaid. They tried to force a really punishing, draconian process on pharmacies just earlier this year. And fortunately, wiser heads prevailed and a lot of protest prevailed. But they were going to basically put a doctor through a hard audit on making sure that they had a yards-long list of check marks on forms before they would allow any prescription over 100 MMED. Now, I don't know exactly what the status of that initiative is now, but if you want to trace the money, I would say there's two sources. One is that addiction treatment specialists want more patients, and they're quite willing to label pain patients as addicts to get them. And two, insurance companies are trying to maintain their profits by basically discouraging the expansion of coverage that would be needed if we ever got around to realizing that there are 100 million people in chronic pain in the United States, and they need treatment. I hope I'm being responsive to your concerns. Do we have other callers?
No, that's it for right now.
Okay, for right now.
I was going to ask you, so Claudia stated that the drug Suboxone would be used as treatment for intractable pain patients instead of opioids. Is this Suboxone an opioid, and what scientific data is there on Suboxone? I've heard it's not a safe drug and there's a lot of side effects. Is this one of the things that they're pushing?
I'm a little bit careful about Suboxone because I don't know as much about its pharmacology as I'd like to. I believe it's a compound of more than one opioid. But at the very least, it basically suppresses the craving that addicts feel. There are unresolved questions concerning its long-term safety, but there is one thing that has stood out very clearly. When Suboxone is administered repeatedly to addicts without referring them into some longer-term treatment program, all you're doing is delaying the overdose, because sooner or later they're going to wind up taking a lethal dose when there's nobody else around to catch it. Well, and that is a very serious concern that has been expressed by medical professionals.
Absolutely. But Suboxone is actually very addictive as well. I know in prisons it's passed around because that's the drug of choice in there right now. So isn't it trading one thing for the other? I've spoken to people and they said that Suboxone is addictive. Why?
It can be, but here's the drill.
Okay.
One of the things we ought to realize is that there may never be a cure for addiction.
Right.
What we have to do is to start thinking in terms of harm reduction. And Suboxone, in some context, might be a part of that solution. But correct me if I'm wrong, but if I'm remembering correctly, Suboxone is still under patent. And if you administer it, it's going to be an expensive solution if it's still under patent. Now, from the perspective of what it actually costs to manufacture, there's no reason for a dose of Suboxone to cost more than $10.
Well,
but it is now up in the $1,000 per hit range.
Right, and a company from Europe made a little film type one instead of the pill. It would be the generic, I think, form. And there's a big lawsuit going on with it right now. It starts with a B, the name of the company. But regardless, I mean, I don't understand, if you're trying to get people off of pills, why put them on another pill,
Okay, let me try you on that, Janelle, because you're raising an important point. May I
sure,
take that a little further? For one thing, when you're trying to reduce harm, what you're trying to do is to take people out of the social context where they use and abuse and ruin their lives and have no possibility of stable employment and no possibility of family connections. Methadone clinics can essentially substitute one opioid for another, and the one that they substitute doesn't have the same effects in terms of creating euphoria, but it does block the cravings for things like heroin. And Suboxone basically does something like that with a little different mixture of opioids in it. So we need to get over the stigma. We need to get past the point of considering addiction to be a character failing, because it's not. And we need to help patients We need to help addicts together to reclaim their lives in some meaningful way and gain a reason to get up every morning. And that means to gain stability in their lives and employment and purpose. And medication-assisted therapy is the most effective thing that we now have for beginning that process. It is more effective than anything else we know. So, yes, there is a certain resistance. It's kind of the Puritans reflected into 2017. There is a resistance that says, well, you ought to take an addict and put him in stocks in town square and throw cabbages at him or her. That doesn't work. That doesn't help anybody.
I guess what my question is like, I'm thinking, okay, Suboxone is being used now, and you can become addictive to it, and it's being another drug that people are abusing now. I don't understand if they're pushing Suboxone. Well, I mean, like, and you know, there's bad side effects. Like, why is that being the new thing that's going to be possibly pushed instead of an opioid?
Well, there's got to be profit. There's got to be profit in that somewhere.
Oh, well, exactly. And I mean, there's not a higher level or lower level in the 60s, 70s, 80s, 90s, 2000s, 2010s. Like, there's still the same amount of addicts that there was in all of these years. Like, really, I don't understand what this whole huge epidemic is, really.
It's mostly hype. The term epidemic itself is a hype, and in fact, I think, and this is a guess, okay? Let's be careful, because I'm not representing this as a fact. When you use the word epidemic, you place an issue in the domain of public discussion that makes it a matter of business that the CDC can address. Mm-hmm. When you regard it as a disorder, it's a matter that the FDA has to address. And what happened in this mess that we're dealing with is that the Physicians for Responsible Opioid Prescription tried to get the FDA to seriously restrict opioids by petitioning them, and this goes back in probably 6 years or so, by petitioning them. And the FDA basically said, well, we can certainly add black box labels to the opioids, but we're not going to take them off the market. They turned down the petition of the Physicians for Responsible Opioid Prescription. And one of the officers of that group of PROP went to his old boss, Tom Frieden, who was director of the CDC, and said, well, we got to do something about this problem. How about the CDC should write the guidelines for opioid prescription, because it is an epidemic. You get the idea here? You see the relabeling that went on?
Right.
If it's an epidemic, friendly forces in the CDC can control the narrative. If it's a disorder or a disease, and there's some argument as to which one it is, if addiction is a disorder or a disease, and opioids are the problem, then the FDA has to decide what the appropriate measures are for practice standards. And the DEA has to decide on what schedule the government will control the substances that we think are contributing to the issue. You know, there's a really remarkable... I'm sorry?
Go ahead.
There's a really remarkable thread in all of this, and I'm going to make an assertion here that is grounded on the work of other people, and that a lot of people will be outraged by. The opioid crisis is not now and never was created by prescriptions given to pain patients. Not ever. And that just outrages some people. But I want to tell you what the logic is behind it. And this is logic that I want to recognize some other authors with. Maya Zalovitz has written about this in Scientific American. Jacob Sullum has written about it in Reason Magazine. Carl Hart, Dr. Carl Hart, who is chairman of the Department of Psychology at Columbia, has written about it in Scientific American. there's a slew of articles from the Cato Institute that also treat this thing. When the U.S. government decided that OxyContin was being overprescribed and abused, and mandated that it was going to become that it was going to be reformulated to stop the abuse. That was about 2010, as I recall. When you look at the number of overdose deaths from heroin from that point forward, they tripled in the next 4 years. And when you look at the number of prescriptions of OxyContin in its abuse-resistant form, it dropped by 2/3 in the same period. You want to tell me those two things are not related?
Right.
Because they are related. The FDA unwittingly forced large numbers of patients who had been using diverted OxyContin, crushing it and snorting it or shooting up on it. They forced them into less regulated drugs on the street, and they killed them by the hundreds.
Right.
In the process. It was an accident. It wasn't a matter of policy, but somebody didn't think through the law of unintended consequences. And that's a theme that is particularly well supported in some of the work that Josh Bloom has published on the American Council for Science and Health. Mm-hmm. So what Maya Zalovitz basically spoke to was the same kind of demographic issues that I just did. And she was the one who started me thinking about this. And she's done some really excellent recent work as well. I recommend her publications. But what she's basically said, and what Carl Hart has said, and many others have said, is that our opioid crisis does involve large numbers of pain pills, but 3/4 of addicts who start on pain pills get them from a family member, or they buy them from a street dealer. They never had a prescription, and in fact, they may never even have seen a doctor.
Right.
And some people, like the Boston Globe, for instance, who have looked at the studies that try to trace drug overdose deaths to prescriptions given to patients. When the Globe did this analysis, or actually when the Globe reported a study of this analysis, when they traced overdose deaths back to the Massachusetts prescription regulation databases, they found that 8% of the people who died in 1 year in Massachusetts from a drug-related overdose had a current prescription for a current or even recent prescription for an opioid painkiller. So what we've got here is when prescriptions were liberalized in the 1990s in an effort to treat more pain patients, lots more got into circulation by theft. Lots more got into circulation by pharmacy thefts and hospital dispensary thefts. Millions of doses hit the street every year from pharmacy thefts, even now. And lots of people who took a prescription for a short-term problem and kept a few pills in their medicine closets created a reservoir of drugs that could be diverted by burglary or by being given to a family member who had a really serious pain problem but couldn't afford the insurance to go be examined by a doctor.
Right. But
so what we've got is the law of unintended consequences, big time. Sorry,
right.
Go ahead.
But if somebody dies also and they have opioids in the system, they don't look. They just say, okay, well, that's an overdose. They don't look at, was it a murder? Was it intentional? Was it not? Was it a combination? Maybe they're drinking alcohol. Maybe they're doing cocaine. Maybe they're doing something else, but because they had it in their system, it's an overdose on that. Like, where are the lines? What are we doing here?
Well, the CDC is doing it wrong very clearly. And as a matter of fact, there is a very excellent article that your listeners can look up on Google. I'm trying to remember the journal it was in. I can check it on my computer if I have a minute. But the title of it basically was Is the Devil in the Data? If you run that on Google, you'll find the article or an abstract of it. And basically what it does is it shows exactly what you're just illustrating by a couple of very well-prepared medical professionals who went back and looked at the CDC data and said, well, wait a minute. The data doesn't tell us where the opioid comes from. And the fact that an opioid was involved, if it's the only thing that's reported when the CDC takes the data, then they're distorting the reality because they're over-reporting overdoses presumed to be from opioids, and they may report the agent, and that means they're going to look and they're going to say, yeah, well, it was heroin, or it was fentanyl, or it was both heroin and fentanyl, or methadone, or morphine, or a prescription opioid. But they never tell you whether the opioid was actually prescribed. That's where the error is, and that's where the CDC has messed up so thoroughly, because they just don't tell you was the substance found in the bloodstream actually prescribed by a doctor. They don't bother to collect the data.
Right. There's a lot of cross stuff, you know. I mean, and the thing is that's why the data is all over. That's why the numbers are all over. And they need to start doing that before they start making these huge jumps and lives are lost, because this is a serious, serious problem, and people are dying. People are you know, and you know, there's a lot of money out there, and I think that's part of what's going on. Markey or whoever called in earlier, you know, that people are saying, you know, why is this happening? It's happening because there's a lot of money involved. And
I think there's some truth to that, but I do want to caution everybody: the trail of breadcrumbs that would put somebody in Leavenworth for 20 years, if it was ever traced, hasn't been completely traced yet. There is a very strong conviction on the part of people in the pain community that big money must be trying to kill them off. And I hear that theme every doggone week in Facebook.
No. Yeah. No, I'm not saying that. I'm just saying somebody like an Andrew Kolodny, why would he come out and, you know, he tells supposedly behind closed doors people, I feel so bad what's going on with your community. But then he comes out in front and you know, and basically says, you know, opioids are the death of everything and it's terrible. And I mean, right. He's very one way. Well, if you're feeling bad for somebody, I can only
attribute one of two possible motivations to Dr. Kolodny. He's either convinced of the nonsense that he spouts every other day, or he has some financial self-interest. And we probably ought to be very careful about this, because, you know, you can't prove a lot of things. You can only believe them, and so I'm voicing an opinion. Kolodny was an officer. He was the chief medical officer for the Phoenix House chain of addiction treatment centers. Right. And in that position, in the last year, it's interesting that he was the one who was on watch when one of their outlets had to be closed because their inmates were regularly using street drugs in the institution during their 28-day detox programs.
Oh, wow.
Now, Reuters reported that incident. It's available online. If you dig hard enough, you'll find it. And you got to say to yourself, how is an addiction psychiatrist who was chief medical officer of a chain of profitable 28-day detox centers, how is he responsible when one of their franchises goes so far off the rails that they have to be closed by state authorities? The other thing that we ought to realize is that a number of other people probably are participating in the finances of all this. We don't know who they are. And we have to be very careful to realize that there has actually been misbehavior on the part of the big pharma companies. That we shouldn't argue against that. A lot of the emphasis on opioids has happened for two reasons, and one of them is a really dumb reason. The dumb reason is that somebody put out an article on a study of about 60 people who were studied on prescription opioids. I forget which one it was, and it might have been OxyContin. And then somebody else wrote a couple of letters about it, and it got into circulation, and it got into the buzz, and the marketing departments of the outfit that made OxyContin latched onto it and started sending circulars to doctors. And suddenly it was like all the doctors were being told, hey, yeah, this is safe, it's effective, and it deals with pain, and your patients need it. What they weren't being told was that there still were risks that they hadn't acknowledged. So Big Pharma told a story in its own profitable interest that wasn't complete. But the other part of this that's really basic is that they told that story in an environment where pain was regularly and widely undertreated. And that's still true.
Yes.
That is still true, despite the volume of opioids that have been prescribed since the early 1990s.
Well,
so you've got...
And now 5 to 6 million intractable pain patients are not being prescribed medications because of this fear and everything else. I mean, it's even more so of what you're talking about. I know what you're talking about, but I just wanted to put that in there, too.
Sure. And I would say the numbers will vary on that, too, because the numbers I see are more on the order of 3 million than they are 5 or 6. But nonetheless, realizing that there are differences of opinion on exactly what the numbers are.
It's going to go up, though. As this goes on, this is going to go up.
It is definitely going up.
There was a new development I was notified about earlier today. The DEA recently raided 26 pharmacies in the L.A. area. And we are all aware of Dr. Forrest Tennant's office that was raided a few weeks ago, and that's in that area. So that means five of Dr. Tennant's extremely ill patients cannot fill their prescriptions. One of these pharmacies is called Sunny Hills. And so now the DEA not only is raiding and targeting pain management doctors, but now pharmacies also. Like, what is going on here? Why is this happening? One of the direct quotes was, we only went after the pharmacies that we thought were prescribing or putting drugs on the street level, or on the street that has no obvious medical reasons to do so, said an investigator. For the first time, the Federal Drug Enforcement Agency is targeting pharmacies they say are behind their growing drug abuse. Federal agents say the warning signs are all over there, prescriptions paid for in cash, patients coming out from out of state, and many who receive the so-called Trinity cocktail, opioids, muscle relaxants, and anti-anxiety drugs all in one. It has been dubbed the Operation Fox Pharmacy, with search warrants served at 31 locations from Hawaii to Nevada to Southern California. We only went after the pharmacies that we thought were prescribing or putting drugs on the street that has no obvious medical reason to do so, said Dave Downing, the special agent in charge of the investigation. The DEA contends it is a balancing act ensuring access to patients who need medicine while keeping prescription drugs out of the wrong hands. What do you think about all this?
I think the DEA is on a witch hunt, and here's a reason for that. And this is something I've also written up publicly, so it's no news. The DEA has been using illegal or extrajudicial tactics against doctors who treat pain patients for years. They've been investigating Forrest Tennant for years. Mm-hmm. But there's a really dirty little secret here. The criteria that they use for identifying a possible red flag, if you want to call that, on a doctor or on a pharmacy, is basically nothing more than the volume of opioids that goes through the practice. They have no training whatever in medicine. A diversion investigator has no criteria for distinguishing between patterns that may reflect a pill mill versus a pattern that would reflect a practice like Dr. Tennant's, which treats a serious number, in his case it's a little over 100, pain patients who need high opioid doses. The DEA assumes, without scientific support, that any high volume of opioid prescriptions represents diversion.
Right.
They just assume it out of thin air. But they have no scientific basis for that. Now, let's back up and add a factor to this, and let's try to be fair. This comes out of testimony that was given literally yesterday to the House Judiciary Committee, to the Senate Judiciary Committee. with regard to an action that they've got going to try to repeal a law that guaranteed pain patients would have access to pain medications. So they had a DEA witness there. The committee asked the DEA witness, we had a record of opioids being sent to a town in West Virginia that had 345 people in it. There were over 9 million pills sent to that town in a year for 345 people. How did that happen? And the DEA had no answer. So we got a real problem because there are still a few pill mills operating out there.
Right.
But the DEA basically is being told any time the volume goes up to a level that seems to represent quite a lot of pain pills for everybody in town, you really ought to be closing somebody down. The Judiciary Committee is slightly off target, and so is the DEA, and neither one of them has figured out what the Sam Hill are doing.
Right. Well, if anybody prescribes over 100 MME, they're going to be looked at now, or whatever they make it be.
Or even lower than that. Doctors are leaving practice. They're just flat deserting their patients outright, no matter what their dose levels are.
Yes, they are. And that's why it's so important that we become educated, okay? And then not only educated, we go out to our lawmakers and make sure they are educated. Because until we do that, this is just going to get worse. And that's the scary thing. And I'm going to have to wrap up here, but I would like to invite you back on so we can go over this all again and go further into this, because this is an ongoing thing. And one thing I'm going to do, at least with my show, and I know I'm going to have Tammy and Nikki Hale doing a show specifically only on this to cover that for every show. But I would like to have you to come back on so we can, I'm going to continue talking about this until something is done correctly here, so
okay,
things are fixed.
And I'll do the same. In the meantime, can I sum up something for your audience?
Please, I would like.
I earlier mentioned this, and I'd like to make it kind of a foot stomper at the end of our presentation. Mm-hmm. Do a Google search on Alliance for the Treatment of Intractable Pain, or do the same search in Facebook. You'll find a Facebook group, or you'll find the archive of some of the papers I've published and the papers that the ATIP is working on. There is an invitation in the source that is maintained on facefacts.org, and the invitation is to a few good men and women, and it invites you to come and talk to us either in the Facebook group or by email, and let us help you understand what you can do to talk with your legislator or their staffs and to demand that the CDC guidelines be withdrawn, because that's a major first step on fixing this mess.
I agree with you. Yeah, and if anybody wants to know what that is, we have it up on our website. It will be under guests. After the show, it will be under archive guests, and then it will say your name, and we'll have that link on there. So they'll be able to see
thank
that.
you very much.
Yeah. Is there anything else you wanted to say before we get going here? And Jen, are you still
No, I need to wrap up. I'm running late, too.
Yeah. Jen, are you there?
I'm still here.
Okay, all right. Well, I just wanted to thank both of you for coming on. I really appreciate it. And let's do this again, please.
Absolutely, anytime.
All right.
Thank
Have a
you
good
both.
evening, guys.
Have a good night, everyone.
Have a good evening.
Yeah.
Carnation, thank you. Thank you for joining in. Thank you for joining. This was a long one here. But this is such an important issue. We need to get this out there. If you have any questions, comments, whatever, please contact me. I will get you in touch with whoever you need to get in touch with. I'm a part of ATIP as well. I belong to a few different communities and in 2 different nonprofits and organizations. And I'm going to be the East Coast trainer for 5-10-minute presentations if you want to go into our state legislatures. So I would love to be able to teach you. So if you want that, let me know, please. All right. We are going to be shut down now for the next few weeks. We will be playing reruns, but I'm going to take a break because we are going to, in the new year, have our new network finally come out. So I'm very excited about that. So we'll have several shows and different hosts that will have very specific shows on certain things. So I will be telling you more about that. Well, I hope you all have a great night. Thank you so much again for joining in, and we will see you soon. Merry Christmas, everybody.
You've been listening to Conspiracies Against Wellness with Janelle Elgaway. Join us next week to get in on the conversation. The opinions expressed on this program are those of the host and callers, and not necessarily those of EXG, LLC, its employees, or sponsors. I'm David Shepard.
The Cause Show with Janelle Elgaway is copyright 2017 by EXG, LLC. All rights reserved.